CataractCoach.com. Anterior capsular tear in a small pupil case. How to successfully finish this case without issues. This is a tough one. Now you can see the patient has a small pupil case here, dense cataract, and the patient's got a lot of head movement there. So it looks like some subtenon's injection was already given. You see that hemorrhage there, making a paracentesis. Oh, a few paracentesis. So probably going to put in some iris hooks. So there we go, the iris hooks being placed with BSS in the anterior chamber. So you can see, keep re-injecting the BSS. And this is so you can stain the anterior lens capsule with trypan blue dye. If you put in like a dispersive viscoelastic here, it becomes more challenging to stain the anterior lens capsule. Because remember, you want to stain under that small pupil iris, right? You want to get that iris opened up. So here, just keeping the AC deepened with BSS, now you can get a little bit of trypan blue dye going inside the eye. Trypan blue dye goes in beautifully, staining the lens capsule. Now, look at the lens capsule. It seems kind of thick. So using a cystotome here to try to get it going. Now, you want to make sure you get a good size rhexis. No baby rhexis is what I say. And you say, oh, look at that. Patient moved right there and caused the cystotome to create another puncture in the lens capsule. So now using forceps to try grab the rhexis and get it around that puncture spot, right? Because even if it's not perfectly round, it's okay as long as the capsulorhexis is curvilinear and intact. But you can see this thickened lens capsule not behaving totally normally. So now surgeon's trying to do perhaps restarting, nicking the capsule again, restarting the rhexis perhaps. But you want to get it a little bit bigger than this. I certainly prefer it bigger. That looks to me about 4 millimeters, just my guess. And again, look how long it's just taking just for the rhexis. These are tough cases. And this is why never short sell yourself. Cataract surgery is a big deal. It's not just some 5-minute procedure. It takes a lifetime to master this surgery. So again, here, really having a hard time getting the rhexis going, you may just have to can open or the rest. So grabbing it with the forceps, let's see. Can you get it tearing? It really doesn't want to tear, does it? Look at that. And you only have a little bit left to do. What should you do here? I mean, you could just pull the capsule towards you, just kind of get a little bit of a widow's peak there and just finish the case. Or you could, okay, can opener the rest, just get it a little bit bigger. You may even want a can opener bigger than this. Remember, prior to the advent of the capsulorhexis, everyone did phaco with a can opener technique, or even there's something called a Christmas tree capsulotomy. Yeah, you haven't heard of that one? Look that one up. Google that one, my friend. Now, let's see what the surgeon's going to do here. So now time for some phaco. Looks like a nice chop technique. Oh, these are some big pieces coming out here. It's a tough case. And now look here towards that iris hook. You know what's going to happen, right? That's the area where we're worried about. That's going to get a run out of the anterior capsular tear. Now, here comes a big chunk of nucleus coming out of the bag. And look at that. There we go. So now you have a rip in the anterior lens capsule. Now, that's usually of no big consequence. The patient should be fine. But you got to be very careful. How do you finish the case now so that you don't have that rip extending back to the posterior capsule? Because that'll be a hot mess then, right? So watch carefully as this professor does a beautiful job. Now, nucleus is out. A little bit of gentle viscoelastic. Now, a Simcoe cannula. So I'd probably use a bimanual IA, but a Simcoe cannula certainly works here. Oh, and another paracentesis there for the Simcoe. So we use the main incision. You have one para, 2 paras, another para, 3 paras. So just at the end here, there are a lot of incisions. Make sure you seal them all up, right? You've got 1, 2, 3 paracenteses, the main incision, plus you've got 5 paras for the iris hooks. So a little bit of viscoelastic going inside there. So at the end, that's total 9 incision. Here's a preloaded lens. And you can see this is probably going to be a little bit of a tight fit. Yeah, it doesn't really want to go in there. So you got the tip in there, but you may want to also switch it. Here it looks like the surgeon has switched it to a different injector, maybe different lens or the same lens in the new injector, and slowly delivering the lens. Now this is nice because this lens will unfold slowly, get it in the capsular bag, nice and easy. I like the slow motion technique here. And then just put it in the bag, and these haptics will open up very gently. And you want to minimize the amount of manipulation of the lens. You don't want to have to mess around with it a lot because more and more manipulation is going to mean you have a higher risk of causing that tear out of the anterior capsule to go backwards towards the posterior capsule. And now you can see the haptics look good. They're opening up. They're about 90 degrees away from, there you go, that orientation. They're away from the capsular rip, which is great. Slowly removing viscoelastic here from behind the optic probably. Is that behind or that's in front? And then now, okay, a little more viscoelastic in the AC. Probably to remove the hooks. There you go, taking out the iris hooks. All those come out. Now probably remove the last of that viscoelastic. Seal this up, call it a day. Woo, that's a tough case. Yeah, look at that, 4 millimeter rhexis. So hydrate up at the end. Make sure you check out the incisions. Beautifully done, Professor. Hey, remember, check out our podcast, the top podcast on all of ophthalmology. That's your 2025 resolution to be a better ophthalmologist, and this podcast will teach you the secrets.